Now, my apologies, Hetal, you're on mute.
Good morning, everyone. My name is Hetal Gohil, and I'm working as a senior manager in Medical Services Department of Hetero Healthcare. On behalf of Hetero Healthcare, I would like to welcome you all to this fourth webinar on HIV and aging. Before we proceed with the scientific agenda that we have today, I take this opportunity to brief you on the Hetero Healthcare, which has been a strong partner with HIV experts across the globe. Okay, we mark more than 25 years of our journey in HIV management. It started with the beginning of manufacturing and exporting APIs and finished formulation of antiretrovirals. Today, Hetero supplies one-third of the global requirement of antiretrovirals. Apart from HIV, Hetero was majorly involved in tackling the national emergencies such as swine flu in 2005 and the latest COVID-19 with the drugs such as remdesivir, favipiravir, and the latest nirmatrelvir. This was possible only due to strong R&D team and the state-of-art manufacturing facilities that have ensured the seamless supply of medicines. 5th June is HIV Long-Term Survivors Awareness Day, which reminisces the long-term survivors of epidemic and raises awareness regarding their needs, challenges, and journeys. HIV long-term survivors include people born with HIV who acquired the viruses during their childhood and are now in their 30s and 40s. HIV long-term survivors are also those who are living with HIV for almost 25 years. With the courage and compassion, they have survived the darkest decades of the HIV pandemic. As we know that the life expectancy of people living with HIV has increased over the years with the improved efficacy of antiretroviral therapy. The Centers for Disease Control and Prevention have estimated that 50% of people living with HIV are now older than 50 years. The goal is to prioritize on improving the quality of life of these HIV long-term survivors who are older adults aging with AIDS, as well as overcoming non-AIDS related physical and mental challenges. To discuss this further in detail, I would like to invite our speaker for today, one of the eminent Dr. Ishwar Gilada, to educate us on the topic of HIV and aging challenges with respect to the long-term survivors of HIV. Dr. Ishwar Gilada is the first person to raise awareness or alarm against AIDS in India in the year 1985. And following that year, he started India's first AIDS clinic. Dr. Gilada is globally acclaimed HIV expert, credited with bringing India on the AIDS control map of the world. He is HIV STD consultant at Unison Medicare and Research Center, Mumbai. He's the President Emeritus of AIDS Society of India, governing council member of International AIDS Society. He is also Secretary of India. He is also the Secretary General of People's Health Organization India, as well as Organized Medicine Academic Guild, which is a national federal body representing 20 professional medical associations. He has also addressed over 4,000 meetings and training programs across India and several high-burden HIV countries. He has also published or presented almost 289 scientific papers. He is actively involved in the prevention, control, and management of HIV/AIDS since 1985. With this brief introduction, I would like to hand over the session to Dr. Ishwar Gilada. Over to you, sir. And I thank you everyone for joining us today. Over to you, sir.
Thank you very much, Hetal, for this introduction. Somehow, 5th June also happens to be my passport birthday. The passport birthday is, your birthday is different. And at the time when we were appearing for SSC, we didn't know our birthday. And we just calculated that you want to become doctor or engineer, you should be 17-year-old when you appear for that 10+2 exam, or that time BSc first year. So I adjusted my date accordingly, and it was 5/6/57, and that is my passport birthday. Okay. So when they declared this is a long-term survivor day, I thought they declared that those people who are practicing HIV and they survive long-term, it may be for them. So I think all three of us, whether hetero healthcare or as doctors working in the field of HIV or people living with HIV, they are all long-term survivors. So they are in different fields. They are like today when we talk about long-term survivors with HIV, you check their blood, you check your blood, you check my blood, it will be almost the same. It's called target not detected. Target not detected is no virus detected. So even in HIV negative person, it will be virus not detected. And even people who are with HIV taking ART, target not detected. That means there is no virus. And no virus means there will maybe some virus, but when you talk about virus per ml of blood or per ml of plasma, it is 0. And to give you just comparison, it can be as much as 2 crore. So from 2 crore, it can become target not detected. Initially, it was a fashion of calling only undetectable. Undetectable depended on what technique you are using. Are you using the technique which will detect up to 2000 or 1000 or 800 or 400? But now there are techniques which detect up to 40 or 34, depending on whether you are using AmpliCor or AmpliPrep or you are using NAT technique. So when you say undetectable, less than 34, it can be 33, it can be 1. But when it says T and D, it's 0. So let me share my slide and then we can discuss further. Okay. So when we talk about what everyone should know about HIV and treatment, and this is a normalization of HIV and aging with HIV. What is important, the people who are going to age with HIV, because if they are not going to die of HIV, and why we talk about long-term survivor and aging, because I remember those days when people used to come around 87, 88, and that time HIV was like a death sentence. Almost up to 2000 year, but in 96 we did start ART, but that was only for those who could afford, and affordability was around only 2% of people, and with the support from family, it was up to 5%. So we used to tell people that abhi aapka zindagi 5 saal ka hai. You decide what you want to achieve in 5 years. And people say, "Are mere maa baap ko Badrinath bhejna hai and 4 dham karana hai, karao." And then they used to say that I want to save for my children, save. And somebody used to come and say that I fight with my wife so much, I don't want to fight anymore because my life is limited. Please do it. So we used to make a 5-year plan, just like a government 5-year plan. And then after 5 years, people came, sir, 5 saal to nikal gaye. What next? Next 5-year plan. Now that 5 year is extended to almost normalization of life. And therefore we talk about people aging with HIV. And when they are aging, they will have age-related complications. They will have age-related diseases. They will have age-related other issues, and they need to be treated for that. So there will be a combination of different medicines for hypertension or diabetes or cancer or for other illnesses or renal problem, and also for HIV. So we need to look at how they could be managed with that. So what I am going to discuss in outline is what is the natural course. So natural course means me or hetero doesn't interfere. You are living on your own with HIV, and what can happen in that natural course. HIV and human being and other STIs. Efforts to prolong life and live healthy. Normalization and fear of death and fear of illness. What are the challenges in the pandemics? And help each other, activism, asserting rights and responsibilities. And are there any laws to prevent discrimination of people living with HIV? So this 25-30 minutes is a short time, but I am going to give you glimpses of each topic. It can be a trailer, but major decision of the hetero, which is supporting this program, is to have a discussion. And I would also like to have question answers and we can discuss. So let us just give you the outline and then glimpses on each of these things and then go to discussion. So what is the natural course? If you look at this graph, a person who is diagnosed with HIV, I'm talking about the when the person is already having a primary infection, that can be in the beginning of the epidemic, beginning of the disease, and HIV is not like Ebola or something like rabies, where you die within a week or 2 weeks. It is a chronic insidious disease. It will take its own time. So usually in natural course, it takes around 10 years or 12 years to go to the stage which is called terminal illness and death. So it was initially HIV, HIV disease, AIDS, and death. And that was considered one-way traffic. All of us know about the traffic. But now with the advent of HIV drugs, ART, that traffic has become bilateral. So it is no more unilateral. And therefore, we hardly call it AIDS, because at any stage, we can revert back that person from any kind of illness or any kind of even terminal illness back to HIV, and that person survives. So when we talk about that, you look at this graph with the CD4 count of the person, which is a marker of our immune system, that initially goes down, again picks up, but start going down slowly, slowly, slowly. The simple example is the Almighty God has given us almost double thing. We have 2 ears, 2 nostrils, 2 eyes, 2 testicles, 2 ovaries if they're female. Similarly, the immunity is double. So what is required for your life, God has given you double. So what happens is to deplete that immunity, because the HIV virus, it start eating CD4 cell. It makes CD4 cell, it is fatty. And once they start depleting, till 50% of the CD4 cells are over, nothing happens because you have already double immunity. Then out of 50%, when they start depleting further, another 50%, that means 75% of total immunity is depleted, then you start getting sick. And that requires 5 years, 7 years, 10 years, maybe 15 years in natural course. And the same red graph is shown that as CD4 count goes down, the virus goes up and leads you to the terminal illness and a lot of opportunistic infections and death. So when you look at the cause, because of HIV, people are dying. It is not always they are dying of HIV-related illness. They are dying of so many other things, and that is because of aging. So it can be AIDS-related death contributed. I'm talking about 2011. So in 2011, AIDS or HIV-related deaths were only 30% or less than 30%. Now they will be further less. So what is happening is to the body is liver-related illness 13%, cardiovascular diseases 11%, non-AIDS cancers 15%, and other unknown causes 32%. So almost 71% people, even in 2011, were dying of non-AIDS related illnesses. So when a person comes to us as a clinician, we come across a person who is diagnosed with HIV and then has a lot of questions in mind. Can I have sex? Can I use condom? Can I enjoy sex without condom? Should I commit suicide? What will happen to my job? What will happen to my sexuality? Do I disclose to my wife or family? What will happen after my death? Should I do only masturbation and not have sex? How do I birth control and relationship? So if you look at that, there are hundreds of the problems, but all hundreds of the problems are almost solved, which I'll show you in my brief presentation. So what is changing trend in STIs? Because if people, there are two ways of looking at STIs. One is that STIs are going up again. Secondly, if the person is living with HIV and aging with HIV, he or she is not stopping sexual life. And not stopping sexual life means that they may not have only a relationship with their own spouse. They continue to have other relationships. So they will continue to pick up STIs, which were not there earlier, which went down in last 10, 15, 20 years because of HIV awareness, condom usage, and HIV prevention programs. But now growing up again. And I'll show you why they're going up again. So what happened? Between 95 to 2005, the HIV awareness campaigns were at top level. So it was not only on the World AIDS Day that we have a HIV program, it was year around, a lot of things were happening. And that time, if the children were born around, say, 95 or 2000, they were hardly 5-year-old, 7-year-old, 10-year-old. they were not exposed to this kind of high profile campaign when they were adult. So when they became adult, around 2015, 20, and now 23, there are no campaigns. There are no high profile programs for HIV prevention. And what is available is only through Google. What is happening through the social media. So they get information, but they get distorted information. They do not get scientific information. So what is happening? Those kind of campaign who are preventing HIV in a lot of people is not happening now. And now we call it cohort effect. So those which were born around that time, around 2000, 2005, they have neither experienced nor benefited from awareness campaign. And now we need to look at innovations. What kind of innovations can be done in awareness campaign? Social media, social networking. This current program, today program, is also that one innovation. Earlier, we used to hire a hall, arrange a lunch, get people, have a LCD projector. Still, some people will come, some people may not come. Today, you sit in a cozy atmosphere of your home and you can still watch. So that is the advantage of this innovation. So social media, mobile apps, invite Tinder and Grinder. So there are apps where people book their sexual appointment, just like you book your doctor's appointment. They book appointment over there. So if you do not invade there, you cannot reach them. They are having a sexual appointment, but they do not know how to prevent diseases. You have to catch them young. College orientation program, medical students and postgraduate, and non-formal youth, because those which are youth are not going to school, colleges, we still need to address them. So what is again happening is that a lot of STIs are increasing, and those STIs are increasing? HSV 1 and 2, HPV, human papilloma virus infection, and we also see oropharyngeal cancers due to HPV. We see syphilis, gonorrhea, chlamydia, and donovanosis. I'm not going to teach you all STIs, but I'm just giving you glimpses as I told. So people are living longer with HIV. A person who is, when we're talking about 15, 20 years back, a person who is diagnosed with HIV, the average lifespan was 32 years for that person. And now it is 71 years, but again, this slide is little older. We're talking about 2013. Now, people are living almost equal to a person who is living. So currently in India, a male lives around 71 years and female lives around 73 years. So the persons are living around 72 or 73 years. So even with HIV, you can live that much. Now, to give you another clue, during the COVID pandemic, we have at Unison about 7,000 registered cases, out of which maybe about 2,000-3,000 may have died. So out of 4,000 people, I had only 4 deaths amongst HIV positive people due to COVID. But among their relatives, their friends or families which are not infected with HIV, they are not under care, the hundreds of them died. That means people with HIV who are under care, they are surviving better life than those people who are not with HIV and not under care. And therefore, it is going to be people be aging with HIV, and they will be aging neck to neck with other non-HIV positive, non-HIV people, and they will have same challenges as the non-HIV population is facing. So our effort is to prolong life and make them live healthy. What do we do for that? Lifestyle modification. We ask them stop addictions. What I have seen that sometimes 2 friends come, one is positive, one is negative, or couple come who is positive and negative. We find that our HIV positive person is more compliant to our suggestions on stopping addictions and changing the lifestyle, doing lifestyle modification, exercise, yoga, but not HIV negative person. So our people live better life. They have a positive thinking. Initially, they thought 5 years life, 10 years life, but now they know that life is unlimited, but still they have that diagnosis of HIV with them, and they consider that we should live a better life with a positive thinking. Helping others, and it will come back to you, and that we advise them that you help others. And like some of the people are also helped by somebody else. Adherence to medicine, and adherence to medicine is very important in HIV. We don't want them to get resistance. Even if they get resistance, we have other drugs available, but they may become costly. Pill burden will increase. Avoid polypharmacy. do not take lot of drugs, avoid polypathy, and stop window shopping. There are a lot of people go doctor to doctor and pharmacy to pharmacy and buy. And sometime when they come to the clinic, they bring a whole bag of medicine. Doctor साहब इसमें से कोई दवाई काम आती है देखो. In our consultation time of 15, 20 minutes, 30 minutes, how much time you can spend on the whole sort of medicine? So we should ask people to stop polypathy, polypharmacy, and window shopping. Polypathy is important because there was one patient who was taking a kokum sharbat. And we didn't know that kokum has a reaction with efavirenz. And patient was taking efavirenz, but viral load was not controlled. So when we asked, what is your dincharya? What do you take? What do you eat? And then he said kokum. And then we said, okay, stop kokum and let us see how it, within 3 months he came and it was virally suppressed. So that means there are some products which we are not aware of. The whole world medical science is not aware of. They are having some kind of combination. They have some problems. Now, secondly, we need to tell people that HIV phobia is bigger problem than HIV. So a lot of people come and they call, they have a weird fear of HIV. And sometime last week, one person called me, doctor, I wanted to talk to you about the gloves used in your clinic. I said, if you are talking about gloves used in my clinic, your fees is double. Because you are doubting gloves or syringe or needle of a well-established clinic which has been practicing a good medical practice for last 28 years. And that kind of phobia people are difficult to handle than HIV. And then we tell them, Googling is a bigger disease than even HIV phobia. So don't Google. The Google can help you to reach to a person like me or any other HIV specialist. But beyond that, Google will distort you. Google will give you a lot of weird information. And sometimes you start palpating your gland and looking at some symptom you have and you try to equate with something like a cancer and you think that you got it. So what is normalization? We have to take out the fear of death and fear of illness from a person. And that has been very well done by antiretroviral treatment. So this is second 95. So when we talk about 95 by 2030, that means 95% people who have HIV, they should know their HIV status. 95% of those people who know their HIV status, they should be on ART, antiretroviral treatment. And 95% of those people who are on ART, they should have suppressed their viral load to target not detected or undetectable viral load. So this target has to be reached by every country in the world by 2030. Initially, it was 90 by 2020, but 2020 we could not reach because of the COVID, and now the target is extended. So basically, we need to look at the target number 2, which is 95% of the people who are on ART. To give a simple example, I gave you earlier also on CD4 count. The normal CD4 count, if you talk about even HIV negative people, is around 500 or little more. And then weakened immune system will be there after it goes down below that, and particularly when it goes below 200. And below 200, they get a lot of other illnesses because of their weakened immune system, and that is called secondary infections. So earlier, it was prevention is the only treatment because we didn't have ART. Now, treatment as prevention. So what has happened, even in government of India or anywhere in the world, rather than investing on a lot of preventive campaign, they are investing on treating people. So by treating a person, for example, in a couple, if husband is positive, wife is not. So wife's education, wife's not having sex, etc. They want to have child, that takes more energy than treating a husband, making him undetectable viral load, doesn't infect his wife, doesn't infect the upcoming child, and they live a normal life. So this has become a treatment as prevention. Now, when we talk about is a man proposes, God disposes kind of scenario, or sometimes we try to understand what is happening in the society. Probably it may have been happening earlier, but we are coming to know now. So there are a lot of non-penetrative sex, hugging, kissing, smooching, masturbation, mammary sex, like they also do sex in between breasts, vibrators, e-sex, orgies, the partner exchange program. As a child, I used to know only in Latur that something is happening in Mumbai. But as a practitioner, we know that there are people who are exchanging partners, and they are a group of 5-6 couple and doing that. Living is become so common, is as much as now marriages in the city of Mumbai. Bisexuality. I used to think, even working in the field of HIV for last 40 years, 37 years in HIV and 42 years in STD, bisexuality is not so common. But now we come to know it's so common. So after the Section 377 repeal, people are coming out openly and talking about it. And so we need to understand all these changing rules of sexuality. So what has been game changers in government of India? It was on 11th of April, there was an act called HIV/AIDS Act 2017, which was initially bill, and the bill was making rounds for last 20, 30 years before that, but finally it is a law. And that law, I will tell you how it is beneficial to HIV positive people. Then there was a launch of test and treat. You test somebody, if found positive, you treat. And third one was launch of viral load testing, because initially we are talking about 90. Last 90 was a viral load suppression. But if you are not doing the viral load, how you will know the person is virally suppressed or not? So they launched that program, and that became viable in the country. Initially, it was a public-private partnership, but now the government of India has supported a lot of viral load centers in different places. And COVID has shown the way that from 10 lab, we could reach more than 10,000 lab for doing PCR. Why can't we do that in HIV? So all this is made possible. You have undetectable is untransmittable. U is equal to U. When viral load is not detectable, how it will transmit to the person? So there is a very simple logic, and that became a major campaign in U is equal to U globally. Now, just give you a glance of how the journey went from a kind of a ART medicine in around 1998-99 to currently 2023. So when we talk about 1998-99, when medicines were made available, was 3-drug regimen, which was launched from 1996. A person used to take sometimes almost 20 to 24 drugs. I'm not talking about vitamins. I'm not talking about supplementary drugs. I'm talking about only ART. Then in 2000, it became 2 medicine in the morning, 2 in the evening. Thereafter, it became 1 in the morning, 1 in the evening. Then after in 2003, it became a compliance kit. All 3 tablets taken at one time. Thereafter, it became 3 in 1. And then in 2006, 3 in 1, that became a norm, not only in India, globally. And I salute Indian pharma companies for making 3 in 1 combination, which made a way for the rest of the world to make 3 in 1 combination. None of the companies in the globe, they made 3 in 1 combination, because 3 different companies, they didn't see eye to each other. But Indian company, whether it's Hetero or Cipla or any other company or MCure, they made a combination of 3 different drugs from 3 different companies by generic and put it together. And initially, people globally laughed at India, but thereafter they followed India. But they never acknowledged that we copied this from India. So this 3 in 1 medicine became so simple. And then now, after that, dolutegravir and bictegravir came, that became again a pill is smaller than the previous pill. You can see the size. And then the side effects of efavirenz, about 5% people used to get a suicidal tendency or suicidal ideation. They used to get depression. Those things are taken out, and we replace efavirenz with either dolutegravir or bictegravir. Then now in 2021, globally it has been approved cabotegravir rilpivirine, and this is a bi-monthly injection to be given. And once virally suppressed, you stop all the drugs and you give 1 injection every 2 months. And I'm sure it was one of the recipients of this generic version. It might be launched within a couple of months. So once, you can imagine, such a ghastly disease, which was giving a death sentence at the diagnosis, has now become, you come every 2 months, take 1 prick and go away and you stay. So that kind of disease has become now. So ART, how it has transitions in India. Initially, we are beggars. We are begging to the rest of the world that, look, our people cannot afford. Make the price affordable. Pharma companies were internationally less reliant. They were not even listening to all of us. They were, when we were going to their stalls at international conferences, looking at our face, Indian, they were not entertaining us. You are not talking to us. That has changed. Then we got so many medicines in hand. Now 1 single medicine. So from being a beggar to a donor, India currently is providing medicine to 92% of the HIV positive people globally. And to some countries is donating, to some countries they are giving a pittance of the cost. And the cost difference is so much that $100 medicine can be for $1 in India. I think this is revolutionized. I don't know why the authorities, they do not acknowledge the contribution of pharma companies, but they have done wonders. So if doctors are able to treat patients, it's only because of our companies who could make generic versions and affordable and accessible medicines. So again, that so many medicines have become only one and it's become affordable, fewer pills, just one, very few adverse effects and more effective. So it was not more is better than small. Then what are the challenges? What is aging, disfigurement, and pandemic? So what do the patient expect from doctor? They want low cost. They want single tablet regimen. They want less adverse side effects. They want no food restriction. They want to survive all sorts of life. They want good survival. They want a smaller pill size. You know, I remember one couple of patients used to come and say, "Doctor साहब medicine बहुत बड़ी अंदर नहीं जाती है." And we had nothing to say. Okay, आप गोली खाओ, एक केला खाओ, केले से गोली अंदर चले जाएगी. And now they need a smaller pill size. No physiological or pathological restriction. So whether pregnancy, whether tuberculosis, whether any other issue, it should not have restriction. Now, what do doctors expect? We want to give better survival to the patient, because if my patients survive, they will come back to me and we doctors will survive or clinics will survive. And they will also bring other patients, because if they survive, and that's how we run our setups. No emergencies from patient management. No, doctors are there for emergency management. But at certain point of time, we also need a peace of mind. We also need a piece of sleep. And therefore, we also don't want somebody to call us at midnight, Doctor, mujhe ye ho gaya. And we have less adverse drug effect. He is in co-medication. So a person, aged person comes to me, I'm providing anti-hypertensive, I'm providing anti-diabetic, I'm also providing anti-HIV medicine. So they should not have interaction. And newer molecules, they should keep on coming and compose all the time. Because if suppose there is one molecule, there is no need of a doctor. The person will go to pharmacy and buy. The person will go to any peer leader and buy and take. So as a doctor, we also want newer and newer combination. Secondly, even if one medicine is replaced by other medicine, some of the side effects are replaced, but some of the new side effects are added. And we need to see even that is taken care of. And knowledge enhancement program, which is happening today, and we keep on doing always. So as I told you, when you should see a lot of medicine and you think that jada medicine khane se jada acha hota hai, it is not like that. So if I were in 600 and 400, there is not much difference. So even 400% will survive and can keep viral load suppressed. TAF 25 versus TDF 300, there is a difference of 12 times. Still TAF 25 works, and the prodrug is almost the same. Darunavir, ritonavir combination, whether 800, 100 one time or 600, 100 two times is almost the same. And even sometimes when virally suppressed, we can give 2 drugs to the person rather than 3 drugs, and it is almost the same. So less is also more, and that is what I would like to impress upon from this slide. Then chronic kidney disease, there are a lot of people who have been popping a pill for their backache or bone pain. Half of the kidneys in India are damaged because of only one drug, and that is called Combiflam. So when this kind of painkillers damage your kidneys, where do people go? And when they come, they say, "Doctor, where is my kidney?" So we need to look at those issues. Then also we need to look at whether TDF is or tenofovir is harming the kidney or bone. And we need to also look at co-medications. We also look at exposure time to HIV infection, how much is required. We have to sometimes weigh between whether heart is more important or kidney bones are more important. Because out of 3 combination, out of 2 combination, one is detrimental to heart to some extent, other is detrimental to bone and kidney. So we need to also weigh and look at. So therefore we need to do baseline test. We need to keep on monitoring every 6 months or every 1 year. Then we also look at the cardiovascular risk, age, sex, smoking. We always take history whether smoking is there, alcohol is there, whether adipose tissues or enough of lipid, and what is the renal damage already done. Then atheroma formation and growth. and plaque instability and rupture and thrombosis. So that can cause the heart problem, that can cause the brain problem. So we need to look at whether this medicine or HIV or medicine are giving rise this problem and how can we stop it. Similarly, some of the PIs, they make person age. They look 5 years or 10 years older than what they are actually, like a progeria. And then there can be treatment failure despite person being very regular in medicine. So it can be a kind of a clinical failure, it can be immunological failure, it can be virological failure. A clinical failure to happen, that means person to get symptoms and new diseases despite being on ART, it takes longer time. The first thing which we can know is virological failure. So viral load testing, it will first indicate, secondly CD4 testing, and thirdly the clinical feature. So we need not depend only on clinical failure, we can intervene much earlier. So you can say medicine started, person has reached to the lower level, but again picked up. So it's not a good medicine, it's called non-initial suppression. And initial suppression is suppress, and again going up. So at this level, at the second level, we need to change medication. Sometimes you can say resemble aging. A person who is having a kind of a side effects of drugs like indranavir initially or D40, either lipodystrophy or lipoatrophy, they look aged than their age. So we also need to do prevention of opportunistic infection. TB can be prevented, PCP can be prevented. Some of the infection like toxoplasma, cryptococcal meningitis can be prevented. MAC infection can be prevented. Candidiasis and CME can be prevented. But what we provide is only co-triamcinolone prophylaxis, which will prevent PCP, toxoplasma, and other at least 10 to 12 infections. And TB prevention, that is because of isoniazid prophylaxis. So also, we would like to prevent some of the infections which can be prevented through vaccine. And earlier, the idea was that vaccines are only for children. In the vaccine for adults are available for many years, but COVID has taught us that vaccine is for everyone. So what we can prevent through vaccine? Hepatitis B, pneumococcal infection, which is 23 type of pneumonia, can be prevented with one vaccine. HPV, typhoid, influenza. And the pediatric immunization should continue as it is. And private sector has been doing this for many years. And we have been asking government of India to initiate or reinitiate hepatitis B and HPV vaccination. HPV is approved. The generic version is going to come. And I think it will be soon launched by the end of this year. So what is helping each other? Prevention, activism, and asserting rights and responsibilities. So when we talk about prevention, prevention is not one, the multi-pronged prevention. It can be a post-exposure prophylaxis, that is after you are exposed, you are given medicine. Pre-exposure prophylaxis, it can be behavior positive prevention, behavior modification, treatment for prevention as task, microbicide for women, male circumcision. Some of the infection can be prevented through circumcision. If there are repeated infection in prepucial skin, treatment of STIs, treating STIs also prevent a lot of HIV. Female condom is an invention of HIV. Otherwise, the female condom would not have been invented. Male condoms, HIV counseling and testing, and behavioral intervention. And vaccine. So vaccine, HIV vaccine is still not there. They're working on it, but may come in next 5 to 10 years. So this is again PrEP and PEP. Act fast. In India, PEP is approved. PEP, again, two types. Professional exposure, that is doctors, nurses, technicians, etc. And non-professional exposure, that is called NPEP, or it is called PEPSA, prevention and post-exposure prophylaxis for sexual exposure, PEPSA, SE. Now, we also need to provide this post-exposure prophylaxis and explain to people how it works, that in day 0, the virus is only at the exposure level. But within 2 days, the virus goes to the collected by dendritic cells and brought to lymph nodes. And after 4 to 11 days, the virus replicates in CD4 cell and releases in blood. After 11 days, it is in every part of the body. So PEP will not work at day 11 onwards. It will not work 4 to 11. Day 3, it may work because it is not explained what happens on day 3. So we give benefit of doubt up to 72 hours. But up to 48 hours, it works fantastically. and PEP should be provided if there is a real exposure. Again, preventing mother-to-child transmission, it was reduced. Now it is to zero transmission. So by providing ART, we reduce the transmission to zero. There is no need of doing a elective Caesar section. There is no need of even stopping breastfeeding. There is no need of even treating a child. If you don't want to, fine. And are there any laws? And I need to know about. Yes, there is a law. As I told you, it's the HIV/AIDS Act 2017. That Act provides and encourages people to take treatment. It discourages people to ill-treat HIV positive people. You cannot disclose their identity. You cannot deny treatment. And if the doctors are denying treatment or people are removing them from job because of HIV status, they can be jailed for 6 months to 2 years. So mandatory consent, pre-test and post-test counseling. No mandatory HIV testing should be imposed as a precondition to providing healthcare. Doctors should extend the same care and support to people living with HIV that they offer to an uninfected person, and they would like to be treated by others when they get sick. So this is one of the campaign which we started long back when Dominic D'Souza was in Goa and jailed. And despite all that, again, discrimination continues. So this headline says in 2018, go back to square one on AIDS discrimination. And this is Stop AIDS Discrimination campaign done at Mumbai Chowpatty. And this is a poster which is invented abroad, but we popularized in India, saying that my friend with AIDS is still my friend. And I have AIDS, please hug me. I can't make you sick, because hugging, kissing, it doesn't spread HIV. So what we can offer today and what we can assure today to virally suppressed person, we provide them full life, and it is as much as life expectancy at birth. So if life expectancy at birth in India is 71 for male, 73 for female, we can offer that much of life to even HIV positive person. No HIV related hospitalization. They may be hospitalized for other things, but HIV related hospitalization will not be there. No HIV transmission to their spouse. So they can marry positive or positive negative and can have baby, and that too HIV uninfected. And most important, none of their life is compromised, whether social life, personal life, sexual life, professional life, or financial life. Nothing. So you are just positive, others are negative. You carry on your life as it is, and life is going on fantastically. So what we need to do, the verdict there is, the one size cannot fit all. So same thing with HIV. Yes, in government, they have only one program, but in private setup, we provide how it will suit you. So individualized cap, 4 C's. What are the 4 C's? Is a cap, you can individualize, hat depending on your head size, cloth, condom, chappal, all 4 C. Then PPA, that is PrEP, PEP or NPEP and ART. So you have to individualize. So in changing time, what Mahatma Gandhi had said earlier was 3 monkeys. Now the 4th monkey is added by us. It is extension of Gandhi's philosophy, and it is abstain, be faithful, and use condom. And expanding ABC to P and P, that is PrEP and PEP. And PrEP is in addition to condom. It is not replacement of condom. So we are known 3 monkeys, but 4th is here to stay for longer till maybe 5th monkey comes. We also want to see that there is no 100% people know their status by 2030. 100% people have access to ART, and 100% people are virally suppressed, and 0 new transmission. So this is possible, and this we deliberate often. We also have done a normalization campaign where theme is "Ye Jeevan hai, is Jeevan ka yahi hai rang roop." In this, HIV positive people, HIV negative people, their families, doctors, pharma companies, and journalists, they were all together, beating the music together. And this gives a good platform where no one knows who is positive and who is negative in the hall. So with this, I would like to thank you for your rapt attention. Here, I do not know whether you are sleeping or you are eating or you are just logged in and not watching. But I presume on Sunday morning, if you are logged in, you must be listening to me. Thank you very much. And I'm here to answer your queries. And this is my clinic, and this is the number of the clinic. And you can reach me also by email or on Twitter. Thank you.
Thank you very much, Doctor.
Yeah.
This is really a detailed insight on the today's scenario in managing HIV and how one can prevent getting infected. Thank you so much. We have few questions with us. We can start those questions, sir.
Yeah.
So one question is from one of the doctor. Do age-related illness occur earlier as the people with HIV ages? Does long-term survivors age faster than the normal people? That is the question.
As I said earlier, ARTs were doing that kind of aging, which is faster than the non-HIV or the real age. There were protease inhibitors, but now the current medicine, they do not age person. So HIV positive person and negative person, they come together, and they 10 years after they come together and 15 years after they come together, they look the same. So I don't think they are aging faster than this thing. Secondly, when we talk about long-term survivors, I forgot to mention there are long-term survivors without ART. We call them elite suppressor, and we have viremic controllers. Elite means those who are HIV positive, antibody positive, but viral load is suppressed, is either less than 40, 34 or undetectable without ART. And there are viremic, that means they have virus, but it is around 1,000, 2,000, 2,000. I have not treated them. I have more than 70 patients who are without ART for maybe 15 or 20 years. And one of them works with me as my attendant in the clinic for 15, 17 years. And every time she says, because I provide free treatment to my staff, so she thinks that I'm trying to save money. So, sir, आप सबको treatment देते हैं, मेरे को नहीं देते हो, but आपको जरूरत ही नहीं है. So every 1 year we do our viral load, and we sure that look, your viral load is suppressed. So everything happening to her, she will try to relate with HIV. But till today, for 17, 18 years, I have not given her ART treatment. So there are viremic suppressors, there are elite controllers. And apart from that, both which are with HIV, on treatment, surviving more than 25 years, that's a broad definition of long-term survivors.
Correct, correct. There is one more question from Dr. Sapna. That is, heterosexual couple want to extend their family. Should we encourage and guide further management? That is the question.
Please do it right now. If you are on Sunday also, you just call them and say that they can produce a child. There are a lot of doctors, I feel unfortunate for my medical community. They aborted such children during pregnancy because of HIV status. They ask them to get vasectomies or tubectomies done. I don't do that. Let them live a normal life. They have also right to be parents, and they cannot infect the child. They cannot infect the spouse. So please do that. No problem. If they are one of them is positive and virally suppressed, no problem. Let them cohabit without condom.
Okay. Okay. There is one more question. That is there medical insurance support available?
Very good question. Is a medical insurance is there? Medical insurance should be provided to every HIV positive person. If a company doesn't provide, you can sue the company under HIV/AIDS Act 2017. We wrote to the company, the conglomerate of that company called IRDA, is the Insurance Regulatory Authority of India. IRDA also issued a circular to all the insurance companies. And I can name, there are two companies which are providing. One is a Star and one is Tata. So Star premium is high, Tata premium is low. They provide all the things except HIV drugs. So if HIV positive person needs to get heart surgery done, knee replacement done, kidney problem, they're all covered. Cancer, everything is covered. So please encourage your people, your patients to get insured. And I think we should take up this in a very big way, because it is very important in the part of the normalization of the epidemic. If you say that they are living a full life and they are not getting hospitalized because of HIV-related illness, then why they should be deprived of other illnesses, insurance?
Correct, correct. Thank you so much, sir. There is one more question, that is, when carbotegravir and rilpivirine combination is expecting in India?
I think there is a medicine patent pool, MPP, at United Nations level in Geneva. They have already provided license to 3 companies. I think Hetero is one of them, but Cipla, Hetero, and one more company. So they can make a generic version of cabotegravir, and that can be made available. So the companies are making survey to find out what is the demand. what could be the costing, and probably it will come out within couple of months, definitely before 2023 ends.
Okay, okay. Thank you, sir. Now,
Current cost internationally is 1.5 lakh per injection. So let this cost be in your mind. And again, I will salute our Indian companies. They will definitely bring it to affordable level in India.
okay. Okay. So there are a few questions where we have patients also who have joined today for this webinar. So there are certain people who are HIV knowledge naive, and we have few questions, like very basic questions.
HIV knowledge?
They very naive people who
Okay.
doesn't have the detailed information on HIV. So basically, sir, these are very basic questions. What tools and strategies can help to manage people who are living with HIV over so many years?
No, basically they should understand they are going to age. They should understand that everything else which is harmful is going to be also harmful to them. So smoking, tobacco, any kind of drugs, any kind of eating from filthy cafeterias, that is harmful to them. So my simple advice when the patient come to me, I will say to them that the same rule applies to everybody, but everybody doesn't follow you, at least you follow. And people, to tell you the truth, our HIV positive people follow, their relatives do not follow. So they stop smoking, they stop drinking, or they reduce their drinking, they stop eating from filthy cafeterias. And when we tell them that you want to eat anywhere, okay, eat, but see that it's just steaming hot. Chapati, dal, sabji, anything should be hot. If you are taking idli sambar, don't take chutney. You don't trust chutney, you don't trust open juices, you don't trust open achar, etc. If you want to drink something, you drink from a pack, Tetra Pak. Don't eat stale fruits from outside. Don't take any kind of juices which are made, because in summer a lot of people drink nimbu pani and sharbat and tarbooj ka sharbat. That can be harmful to them. So only these are the advice. Otherwise, no special advice. You live a very good life, no problem. You take very punctual with medicine. That's it.
Okay. Okay. So there is one more question from the patient. That I have kept the name secret, that is anonymous. I'm taking dolutegravir for more than a year and have gained body weight. So what can be done to overcome this?
You see, we tried different methods. When we give dolutegravir or bictegravir, we tell them that you are likely to gain weight, and that weight gain will be around 3 to 6 kg in 1 year. But in the second year, it doesn't, it stabilizes. In many cases, weight gain is a status symbol. And the family becomes so happy that मेरे बच्चे का आपने वजन बढ़ा दिया डॉक्टर साहब. मैं बोला मैंने नहीं बढ़ाया, दवाई नहीं बढ़ाया. But what we need to look at is, because of the weight gain, are there any kind of other parameters which are derailed? Whether there is a sugar, whether there is a hypertension, whether there is other problem. So long as that is not there. Secondly, when you tell in advance to people that they are going to gain weight, you tell them, by doing exercises, by doing cycling, by doing walking, by doing swimming, you can neutralize that weight gain. And people have done that. So I think there will be no medicine in the world which will be without adverse effect. Even water cannot be without adverse effect. So we need to tell that there will be adverse effect, but how to utilize them, that is also to be advised to the patients.
Right, sir. Okay. There's one more question that is on COVID and HIV impact. How much an HIV patient has danger to succumb to COVID-19?
I think those HIV patients who are on ART, they had less dangers of COVID than other non-HIV people. And that's what is anecdotally found out in my clinic. There are other clinicians across the world, they also try to collect that information, that whether impact of COVID is more on HIV positive people versus non-HIV. It is not more, definitely not more. And those which are on regular treatment, it is much better. So as I told you, I lost only 4 patients out of my 2,000-3,000 which are following up regularly. But among their relatives, their family, friend, brother, sister, they have lost hundreds. Okay. So, what happens is mainly, and it can be message to everybody, that we as a human being, we earn a lot. We try to maintain our air conditioner, which is costing only 15,000-20,000 rupees, and we make an annual maintenance contract. We buy a car for 5 lakh, 10 lakh, we make annual maintenance contract. For everything which is perishable and can be bought for pittance of money, you make a contract. But for a body which is costing more than a crore, 2 crore, 10 crore, whatever you want to calculate, you don't want to do annual maintenance contract. HIV positive person goes through rigorous checkup for every time when they come. But non-HIV person, they do not go through any checkup. I have seen HIV positive person, husband surviving, wife non-HIV dying. I have seen such many cases. Among two brothers, one positive, one negative. A negative brother died of heart attack, positive is still alive. So I think people should look after their health. If you are doing an annual maintenance contract with any, is not AMC with the doctor, but you do annual medical checkup. How much it will cost? If you calculate it's a pittance. If you calculate it maybe just a 200 rupees a month or so, if you calculate 2,400 for a year, it is not much, but it will give you indication. Secondly, when any town, you have a fire brigade, and for last 2-3 years, there is no fire. It doesn't mean that fire brigade is not required. So for doing 2-3 tests, you say, "Mere ko kuch aata hi nahi, kyun test karu?" That is also wrong. Keep on doing the test. Sometimes you will find something which can be corrected.
Right, sir. Right. There's also this question which has come up that body color tanning occurring with dolutegravir but not with bictegravir. Is it correct, or is there any science?
I did not see any body color change, so I cannot comment. So body color change maybe because of tanning, you going in sun, going in kind of a tangential light around 10 to 11 in the morning or 4 to 5 in the evening, which ultraviolet A rays that tans your body more than a vertical rays coming at 12 o'clock noon. So it depends on a lot of factors, but I have not seen, and it is not known that any kind of drug causes body tanning.
Okay.
One drug can cause body tanning, which is known is clofazamine, and that is used in MDR tuberculosis and leprosy. So if the person had TB and was treated with clofazamine, it can be giving rise tanning.
Okay, sir. Okay, there is one more question. With the syphilis upsurge, what is your treatment choice? The gold standard penicillin difficult to procure, or doxycycline is sufficient? And with aging, we do have to think a lot of latent syphilis. Please guide.
You see, the gold standard in syphilis treatment remains is only penicillin, long-acting penicillin, or it's called LA24 or LA12. LA12, if you are taking, there's a 12 lakh dose, then you need to take 2 at a time, and minimum 3 doses. 2 doses suffice, but 3 is better. So if you have a lack of doctors who would like to give injection, 2 is enough. Secondly, there's a shortage of penicillin. There are only 1 or 2 companies making penicillin and making it available. So we are urging to the government, because there are a lot of issues which cannot be discussed in this forum, because this is a DPCO, the Drug Price Control Order, and they bring a lot of drugs in DPCO. As soon as the drug brings in DPCO, there is no margin left for the manufacturer like Hitro or any company, or many like penicillin drug is available for 20 rupees. 20 rupees a vial, 24 lakh units dose, provided with the water which is to be given. How much money they are going to make out of it? So penicillin is not available, and therefore they are using either doxycycline or azithromycin, but they are no way closer to penicillin. Syphilis, primary syphilis, secondary syphilis, they are very well managed with Penidura. If you don't do that, then you lead to the tertiary or quaternary syphilis, which is involving brain or heart, and that is going to give unprecedented and irreversible damage, where it cannot be controlled or treated with long-acting penicillin. So I think we should look at it. And syphilis is 100 times more transmissible than HIV. So a person having HIV, hepatitis C, hepatitis B, and syphilis, all 4 infections, and you had a sex with that person without condom, your chance to pick up HIV is only 0.3%, 3 in 1,000. Hepatitis C is 3%. Hepatitis B and syphilis is 30%. Syphilis can be transmitted by kissing, by smooching, by masturbation, by touching. Secondary syphilis is so contagious that even a physician can contract syphilis from treating a patient. So understand, syphilis is not that simple, and therefore it was since beginning called king of diseases and disease of kings.
Okay, right, sir. Thank you so much. There is one more question, sir. This is regarding one patient who is talking about his CD4 cell count. So my CD4 cell count is consistently at 500 to 700 cells and not touched 1,000. Is it a cause of concern?
No, it is something which is part of your immune system. Everybody's immune system cannot reach 1,000 or 2,000. I have patients which have reached up to 1,800 or 2,000 CD4 count also. But so long as your CD4 count is around 400, 500, you can donate your remaining 300 CD4 to other people, but there is no provision of donating. So 500, 700 is absolutely fantastic. Don't worry.
Okay. So there's one more question, that is, can HIV get transmitted through oral sex? In both the cases of giving and receiving oral sex, is it possible to get infected by HIV?
I used to say no earlier, but after having 2 cases in my clinic itself, where the only and only oral transmission, oral sex giving HIV, I stopped saying that oral sex doesn't give HIV. So you do get HIV in oral sex. It depends on a lot of conditions. It could be oral ulcers, it could be gingivitis, it could be dental infection, periodontal infection, it could be forceful and for longer time. I don't know what are the reasons. That is not my area of expertise. Secondly, we have also seen from a Tata hospital study that 50% of oropharyngeal cancers are because of HPV. And HPV is transmitted sexually. So they are all because of oral sex. So oral sex, you don't worry only about HIV. You worry about many other infections, including syphilis, gonorrhea, chlamydia, herpes, HPV. So I think whether you are having oral sex, anal sex, vaginal sex, it should be protected. It should be completely condom protected from start to end.
Okay. So there's one more question, that for international travel, do I have to reveal HIV status, as I may have to carry medicines? Visa will be affected?
See, a very good question and very intelligent question. People who are traveling internationally, or they want to be shifted for some job somewhere, if you are carrying your own medicine, not for commercial purpose, nobody would stop you. What do you need to do? Number one, put medicines in your check-in bag. Don't put in handbag, because handbag is at many places, even in a transit airport. So everywhere they'll be asking you question. If you put in check-in bag, it is at the check-in and check-out. Only 2 checks are there. Number 2, if somebody does ask you what is there in the medicine, what is there in the bag, which medicine, sir, it is for my personal use. Don't disclose HIV. You are not supposed to disclose HIV everywhere, because people might discriminate you. They might ask you a lot of other questions. This is for my personal use. And always carry prescription handy on your mobile. The next question will be, do you have a prescription? Yes, of course I have. Say confidently. If they ask the next question, you can show on mobile. Prescription doesn't show you have HIV. It shows some this and this medicine or any kind of contents. They're not shown HIV. If thereafter also they ask, somebody is really intriguing, then say, yes, of course I have HIV and I'm carrying medicine for my own use. So if you're carrying up to 6 months, no use. Sometimes you can carry up to 12 months also. Courier are only sent for only 3 months. So courier restriction is only 90 days. Sometimes to help people, we have to write one medicine twice a day, so that at least 3 months can be 6 months for that person. But 6 months you can carry safely without any reason.
Okay. So there is one more question, which is from again a patient. This was
one minute. Don't remove the label of a medicine. Don't put it in something else. You can put in something else, but that should have a label. Because if they open the bag and they say that it is unlabeled, then they give you more doubt and more trouble.
Correct, doctor. So there is one more question, that if the person has developed drug resistance, what are the medications or strategies that will help in managing HIV if the person has already developed resistance?
No. You see, there are different treatment algorithms. But if you have developed a really resistance to first line, second line, and you have been on drug for many, many years, you need to go through a complete drug resistance profile that will chart out which drug will work. Usually, dolutegravir and bictegravir, they are new, being new drugs, they are not resistant to that. And integrase inhibitors, among them was a raltegravir, which was used for longer time. That has a poor resistance profile, but these are very strong resistance profile drugs. So these drugs and darunavir, these are the robust drugs and they can work. So if you can afford a full resistance profile, do it. If you cannot afford, then you can start dolutegravir and darunavir, or you can start bictegravir and darunavir, and that they will work.
Okay. Okay. There's one more question from a patient saying that can one take a break from HIV medication?
Yeah, you told me earlier I can also take a break for a couple of seconds. Similarly, one can take a break, but they have studied scientifically. It was called structured interrupted therapy, SIT, and unstructured interrupted therapy. Unstructured people unstructuredly break many times. A lot of Muslim patients will say that during Ramadan we didn't take. Some people going for pilgrimage they didn't want to take. Some people going for wedding ceremonies they didn't want to show to their friend or family. So that is unstructured. Structured was also 1 month on, 1 month off, 15 days off, 15 days on. They studied all that. They realized that it damages and the damage may go beyond repair. So patient may become resistant. So please do not do any such kind of trial. There are other people who are made for such trial. Let them do, come out with a solution and we'll take. So don't take any kind of, but if you want to take a break and restart. Don't break off and on, off and on. There are a lot of people who are very poor adherent. Every time they come on follow up, we find out on the case sheet. Sometimes we need to work as a police or CBI or CID. I ask, my receptionist will ask again, counselor will ask, and then somewhere they will have to tell the truth. And they have been off and on, stopping and starting. Sometimes financially they want to stop on, off and on. Sometimes they share the medicine with their family. Off and on is bad. If you want to put off, fine, and then restart, and then you do not put off.
Okay. 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 So there is one more question that if the patient is suffering from many comorbid conditions like hypertension, diabetes, and the person is already on ART, how to overcome the toxicities which can be produced in the body?
Therefore,
manage that.
When you are going to a diabetic or a hypertension clinic, you don't have to tell them that you are on ART, because I have seen such people telling them, and the doctor increased the fee. They started kind of discriminating them, suddenly started putting mask and gloves as if this person will carry HIV to them. So don't disclose. But when you come to HIV clinic or ART center, you disclose there that you are taking this medicine. And we have a way to find out whether this medicine will interact with your medicine. So if you don't want to carry prescription, you carry the medicine, and we can see whether that medicine will act or not. To simply giving you example, if you are taking diabetic medicine called metformin, more than 1 gram should not be taken with dolutegravir. That will react. Or if you have to take, then you take dolutegravir separately and this separately in morning and this is in the evening. So when we take diabetes medicine, it is usually given twice. So you can take before breakfast, before lunch, and before after dinner you take dolutegravir. So you need to time accordingly. So accordingly, what medicines you are taking, there is a chart available with us. We look at that chart and tell you, okay, this is not okay. And then you can go and tell the doctor that I need to change this medicine to this. Because sometimes the patients are not comfortable, HIV physician changing their diabetic or hypertension medicine. Because as much faith they have in us, they have that similar faith in that other doctor. So we ask them, okay, now you go and tell the doctor that you are having a problem with this medicine, you can change that medicine.
Okay. Okay. So there is one more question that is one patient saying that I am HIV positive and my wife is not. Should I disclose it to her? I fear being evident.
Ideally, in a conjugal relationship, you should disclose. If you fear of disclosure will lead to some problem, you bring such patient to any kind of counselor or doctor who has experience, they will disclose. You expect some backlash, but that backlash will not be divorce. The backlash will not be you being hit by your wife. So you don't worry. And secondly, I have seen in last 42 years of my life, women have a larger heart and women have a very strong will than the men. Usually we think that women will cry, men cry here. Women have a tendency of forgive and forget. Men are not. So though I'm a man, I'm a feminist and I can say that with authority. So disclose to your wife. If not possible, bring it to the clinic or any counselor. Please do that. If you still want to carry on like that, no one can change because there is no law which can enforce you to do that. But if the wife finds out about your status and she goes against you, then that becomes a legal case. And in two such cases, I had to go as a witness in the witness box and say that I told my patient to disclose to his wife, he didn't tell. Because what has happened, wife came to our clinic and he said that shown the prescription of my husband and take medicine for 1 month. And when she took, she Googled and she found out that this is for HIV. And she accosted husband. She filed a case against husband, father, brother, and doctor. And I became witness and I said that, yes, I told my patient, do not get married or get married with a disclosure of your status. And he didn't disclose. So there are such cases. So it's better to disclose. And if you cannot be, then bring to the person who can disclose it properly.
Okay. So there's one more question from one patient, that in case of discrimination at workplace, where can I go for help, or any social stigma? How can I overcome it?
Very good question. I need such kind of people who would challenge such kind of discriminatory places, file a case against that person or that authority under HIV/AIDS Act 2017. Secondly, there is a provision that a person filing a case who is HIV positive need not disclose his name or identity. He or she can be Mr. or Miss XYZ or ABC. So, we have to teach lessons to these people because they are sick, because discrimination is a mindset problem. It is not virus per se. So, for example, a kind of a childbirth or pregnancy is a pregnancy. But if there's a pregnancy after marriage, it is called good news. And if pregnancy before marriage is called bad news. So it is our mindset which study says that. So there are people who will be discriminating and there will be mindset change needed. But we need to file cases. Otherwise, till today, there is not a single prosecution with using this law in last 6 years of the law.
Okay. So there are a few questions. With your permission, if we can go.
I have also taken more time because Vijay told me that, sir, we have no limit. So I thought if I cut my slide, then a lot of meaning changes. And therefore, I think took around 40 minutes rather than 25 to 30 minutes.
No problem, sir. No problem. Okay, sir. Okay. So there is one more question which has come up, that is how one can overcome extreme fatigue which is seen. How to help extreme fatigue?
Fatigue, okay. No, I will. Very good question. Very intelligent question again. During the COVID, a lot of people have developed deficiency of vitamin D3 and B12. And not only fatigue, they have developed also erectile dysfunction, sexual problem, irritability. And this is because of COVID. Because of lockdown, you are not exposed to sun. Because of COVID-related medicine like remdesivir, etc. So I don't know what has caused the problem, but there is a problem. So either get your vitamin D3 and B12 checked, and even if you don't want to get checked, take supplement of vitamin D3, because vitamin D3 is cheaper than vitamin D3 test. It is to be taken once a week for 8 weeks. Any of the product of vitamin D3 you can take. And during that period, you also need to supplement yourself with calcium. So when you are taking vitamin D3 once a week for 8 weeks, you take 8 weeks of calcium supplement. And similarly, if you have also stomatitis, glossitis, tingling, numbness, lethargy, then you can take B12 support. And B12, if it is extreme deficiency, you need injectable, at least 5 injections. But it is not extreme deficiency, tablet will help.
Okay. Thank you, sir. Thank you. So there is one more question, that what is the impact of ART treatment on adherence and how it impacts in improving quality of life?
Again, very good question. I think this is a very experienced person asking this question. ART has impacted adherence. Earlier, when TLE, means efavirenz-based regimen was there, a patient used to come and say they have some problem. they are getting depression, they're getting bad dream, they don't want to take, they get dizziness, they get suicidal ideation, and we used to convince that person, ले लो यार कुछ नहीं होता है, दूसरा कोई medicine नहीं है, we don't have better option, other medicines are expensive, and the person will say yes, yes, but after that didn't take medicine. And that we started knowing only after this dolutegravir or bictegravir came, and then they said, sir, ये medicine से अच्छा है, वो medicine हमने खाया नहीं 2 साल, और 6 महीने खाया नहीं, 1 साल खाया नहीं. So now we proactively ask them, do you have a problem with efavirenz, so that we can shift you to this, and then they are now telling. So efavirenz 600 problem can be solved with efavirenz 400, or shifting them to this integrated-based regimen. But less number of medication, less number of adverse effect, pill size, etc., all matters in adherence, and that we have seen that the current adherence is much better than the previous adherence. Even in the government program, after 2 years of their launch of ART, after 2 years or 3 years, I don't remember, but there was 31% people had a non-adherence, or they stopped going to the ART center. So that was mainly because of the efavirenz-based regimen.
Okay. So there is one more question, that is the role of nutrition in managing HIV, or is there any specific diet to be taken?
You see, role of nutrition was there in the absence of ART. It was there in the absence of the newer ART. It was there in our mindset earlier. But now currently we do not find any role of nutrition. We just ask them what your other family is eating, you eat the same thing. We do not give them any, because to help normalize the epidemic, to help normalize the HIV, we need to make them normalize everywhere. Because they do ask questions, हमारे कपड़े अलग रखना है क्या, हमारा खाना अलग बनाना है क्या, हमारा चाय अलग चाहिए क्या, मेरे भाई का बच्चा मेरा कब से चाय पीता उससे कुछ होगा क्या. Nothing happens. So we do not give any such restriction. Only thing we tell them that what is good food, what is stale food, how to avoid infection from food, and ask them to, if they are already putting on a lot of weight, we ask them to have a low cholesterol diet, high protein diet, high fiber diet. We ask them to take more vegetable, more fruits. So that we advise, but that is irrespective of HIV.
Okay. There is one more question, sir, which is on immune system. So there is constantly there is activated immune system, and how does it affect the accelerated aging which is seen?
See, again, this is a very good question. There's in accelerated aging, there's aging and accelerated aging. Firstly, there is no accelerated aging in HIV. So let us put aside. In aging, what happens? There's an immunosenescence. Immunosenescence is like I lose every day, say up to 70 to 110 hair loss is a normal hair loss. If I lose that much hair, my body should make that many hair. But as you grow, your body doesn't make that much hair. Similarly, sebaceous glands are not made that much. Similarly, CD4 cells are not made that much. Or even spermatogenesis is not that much. So your body will stop or it will reduce making those things. And that's the reason you get wrinkle, the fat is going down. You will get the process of aging is not only in CD4 cell, it is in everywhere. CD4 cell is called immunosenescence. Your immunity will little bit go down. Therefore, when you grow, kind of a healing process is slow. Any kind of infections getting is faster. If somebody coughs, and that's the same thing we are taught in during the COVID, that we need to protect our 60 plus population. We need to protect those which are with comorbidity, because they can pick up infection faster than young people. And therefore, that is part of your aging. It is not accelerated aging in HIV. There is nothing like accelerated aging in HIV.
Okay. Thank you, sir. There's one more question from the patient, that I am HIV positive and I'm on the medication, but need to know how it will get reduced. Treatment.
You want to reduce HIV or reduce treatment?
They have mentioned how it will be reduced, the HIV infection.
No. You see, that is a HIV cycle. HIV life cycle is that there is a RNA virus, RNA virus cannot multiply without becoming DNA. To change from RNA to DNA, there's an enzyme called reverse transcriptase that helps the virus to become DNA. DNA of the virus and DNA of the cell, host cell, that multiply, that mingles, that become combined, and that redivides and make another DNA. That's a new virus. That DNA will again from reverse transcriptase will change to RNA, and that RNA, because of protease enzyme, it will go out and with a budding, and the new virus is there and go to new cell. So this is a cycle. What happens is when you are giving a drug, which are at least at two level they act. So one is a reverse transcriptase inhibitor. That means RNA cannot be changed to DNA or DNA cannot be changed to RNA. And number two, integrase. Integrase means when DNA combines, the enzyme which is integrase is inhibited by integrase inhibitor. So suppose a virus entered a blood cell. We are talking about a HIV positive person because we are giving a treatment. We are not talking about PEP or PrEP. In HIV positive person, one cell is infected, other cell is not. I'm not talking about thousands of cells. One cell is infected, other is not. So the virus has entered from that cell to a new cell. The new cell, that reverse transcriptase as trying to make RNA to DNA. Your RTI inhibitors, two drugs which we are giving, they will stop not allowing RNA to become DNA. If that RNA is not become DNA, the virus will not multiply. The virus has to become DNA. The DNA combination will only multiply. If suppose for some reason NNRTI did not work, that RNA became DNA, that DNA trying to combine, your integrase inhibitor will stop that combination. So DNA doesn't combine. If they do not combine, they cannot redivide, they cannot make new virus. So your cell, even if there is a virus in the cell, that cell has a life, like we have a life of 71 years, 72 years. The cell has a life of 72 days. After 72 days, the cell will die its own death. It's called apoptosis. It's a cell death. So the virus will die with the cell will die with the virus. Virus is allowed to go out of the cell. In a simple example, husband and wife both, if you tuberculomize wife, husband can produce somewhere else. If you vasectomize, wife can produce from somebody else. But if you tuberculomize and vasectomize the wife, they cannot reproduce a child. And same thing, we are tuberculomizing and vasectomizing the virus, not allowing to multiply. And that is the job of the ART.
Right, right. So there are a few more questions. Okay. Sir, there is one question that there are shortages at times in the ART centers. What should we do in this situation?
See, this is a very tricky question. And stockouts are there, were there about 1 year before. They are no more there. There were some issues, challenges. There were issues of tendering from one company, that the product of that company was not good. They had a retendering. The retendering is a process of 4 to 6 months again. So those are different issues. Don't bring it here. But if at all there is a stockout, I am of the opinion. Please do not take it otherwise. Government is not duty bound to supply you for lifetime. Government has not given you HIV. You got HIV from somewhere. Government is trying to provide you, and for some reason there is a stockout. You buy from somewhere. It is available. It is affordable. It is accessible. So, and this is only for that 1 or 2 or 3 months. There are people who are really unaffording, cannot buy anything, but there are charitable organizations which will support them. There are even clinic like us. We support people, though we are not mandated to, for those people who cannot afford. So please do not bring in stockout as non-adherence. Right. You should be able to buy at least a couple of months of supply, and the government will come back to normalcy. Secondly, government after a few years may not give you ART. Then what will do? You will stop ART. So you should make a provision of your own way. Like from 10 years, government will give, and in 10 years we'll save so much that we'll give, we'll be able to buy ourselves. And lastly, our job as a doctor, as a government or anybody, is to keep you alive, to keep you healthy, to keep you earning. Earn and look after your family and spend. If your spending is more than earning, then it is difficult. If you are earning 50,000 a month in India and buying a cabotegravir injection for 1.5 lakh from abroad, it is unaffordable. But if the same cabotegravir is made available for 5,000 or 10,000 or 7,000, and by 50,000 you are able to pay that much, good enough, take it. So I think this is a very, very simple logic. So this stockout is a very difficult topic to discuss. You can have if that is a community person asking, I would like to have a meeting with community anytime when they want, and it is free of charge. So anytime community can contact and we can do that meeting. We are done even during lockouts, the stockout. We were the first professional organization to intervene. We talked to government, and within 24 hours after writing and sending a message to the health minister, things change. So things change. It is not that government doesn't work. I'm not working in government. Many times I talk against government. But in this situation, government is trying to do much better, and our government has done fantastically. So I think even dolutegravir was brought with a lot of pressure. We are sitting on committee. A lot of other countries, even African countries, poorest of the poor countries, got dolutegravir earlier than India. But finally, they accepted. So I think we need to look at a lot of issues in stockouts.
Okay. Sir, just two more questions with your permission.
Yeah, go ahead.
Okay. So there is one question, which is, can two HIV positive parents have a HIV negative child?
100%. We have 170 children born through the intervention of our clinic in last 7 years. None of the child is positive. Okay. And the last week there was a surprise visitor from Canada. He is getting married to an Indian girl, and he said, "Sir, you change your life." He brought a sweet, and he said, "Every time I want to come and see you for 10 minutes, will you allow?" And I said, "Why?" He said, I came with my girlfriend that time. I'm positive, she's negative, and she continued to love me, and we are getting married. I think marriage is this week only. So they are marrying, they are producing child. None of the child is infected. So it's a very good development for those who are HIV positive. One more thing, lastly, I can say that if Almighty God comes to you and saying that I want to give you choice and you must take one disease, diabetes in my right hand and HIV in my left hand, you must take one disease. We don't want to take any disease, but God is insisting you must take one disease. You take HIV, don't take diabetes. HIV is that simple, that easy to manage, that better to manage than diabetes.
Okay. So there's this last question which we'll take, that the patient is taking ART as well as anti-rheumatic drugs such as an immunosuppressant, that is mycophenolate mofetil. Does it affect the overall immunity, and how to overcome that if it is affecting my immunity?
No, you see, when you are taking ART, which is a very powerful drug, it will increase your immunity. I have seen patient of one CD4 count going to 700, 800, or 1,000 count. I'm talking about one CD4 count. Number two, when we started getting patients of lymphoma is one of the HIV-related cancer. And because I am not an oncologist, I referred the patient to Tata Hospital. Tata Hospital said that if patient is going to die anyway, we don't want to intervene. I said, no, you look after only lymphoma, I will look after HIV. I'm talking about the pre-integrase era, pre-PI era. So even in that era, they listened to my advice and they continued treating lymphoma cases. When they got 50 cases of lymphoma, they did a seminar on lymphoma and they called me to chair that session and say that because of Dr. Gilada, we started treating lymphoma in HIV positive patient. Earlier, we used to think that HIV patient are going to die anyway. Why we should treat lymphoma? So I said, you manage lymphoma, I manage HIV, and combination we manage both, and they're surviving. So this gives a classical example that even if there's one immunosuppressive drug or disease, and you are taking ART, still ART drug is superior to that immunosuppression, and it will overcome.
Okay. So we have finished with the Q&A session. I would just like to thank you, sir. Thank you, Dr. Gilada, for enlightening us today on the HIV care and management. With your great insight and rich experience in HIV management, you have educated us briefly on all the aspects of HIV treatment, its prevention, the comorbid conditions, how to overcome those the episodes of fatigue and how to manage that, how to improve quality of life. You have touched on all the aspects of HIV management with your rich expertise in this field. I thank you very much, sir. Thank you so much. On the behalf of entire Hetero Healthcare, I would like to extend my thanks note to all the participants for patient listening and posting your questions, for making this session more fruitful one. So we can call this Sunday as a more scientific Sunday. We have enlightened us the knowledge on HIV and its management. Also, I would like to thank you on the behalf of Hetero, the entire head office team, our field colleagues, and the IT support, the technical team, for organizing and for managing this webinar so well. Thank you, everyone. Thank you so much. Thank you, Doctor.
Thank you.
We can officially close this meeting for today. Thank you all for patient listening.
Thank you. Thank you, Vijay. Yeah. Vijay, come out.
Yes, sir. You can go ahead and discuss.
Okay.
Very nice session, sir. Very nice session.
It was such a wonderful session, sir. Thank you so much for giving us this time on Sunday.
Thank you. Thank you.
Absolutely, sir. We thought about 1 hour, but then 1.5 घंटा कैसे निकला